Hello, ladies and gentlemen. Hello, everyone. Our new program, Chronic lymphocytic leukemia and associated disorders. Chronic lymphocytic leukemia is an indolent lymphoid disorder involving a clonal expansion of CD5 positive B cells, nucleoside analogues in combination with alkylating agents and or monoclonal antibodies have produced marked improvement in remission rates. There is now evidence of an improvement in survival with chemoimmunotherapy. Epidemiology. Chronic lymphoblastic leukemia is the most common leukemia in the Western Hemisphere, accounting for 20% of all leukemias in the United States. This disease is uncommon in the Asian population and accounts for only 2.5% of all leukemias in Japan. The incidence is age dependent with an increase from 5.2 per 100,000 persons older than 50 years to 30.4 per 100,000 persons older than 80 years. The male to female ratio 1.51. Cytogenetics. Using conventional chromosome banding techniques, cytogenetics abnormalities can be detected in up to 50% of chronic lymphocytic leukemia cases. These techniques are hampered by the low mitotic activity of chronic lymphocytic leukemia cells. B cells mitogens may be used to enhance this activity. In addition, metaphases obtained for karyotyping may also arise from normal T cell in the sample, as indicated by sequential immunotyping followed by karyotypic analysis. Resistance to apoptosis, programmed cell death, CLASSİCAL. Resistance to apoptosis is feature of chronic lymphocytic leukemia cells, and many mechanisms have been proposed for this resistance. Recent experiments have described a subset of peripheral blood mononuclear cells in patients with chronic lymphocytic leukemia that differentiate into nurse-like cells in vitro and can protect chronic lymphoblastic leukemia cells from apoptosis. Clinical features. At diagnosis, most patients are older than 60 years, with more than 90% being over 50 years. The diagnosis of chronic lymphoblastic leukemia is the often incidental routine blood counts may reveal an elevated absolute lymphocyte count. In symptomatic patients, fatigue and infections may be present in future. These symptoms, fever, weight loss, can also occur but are uncommon. A small percentage of patients may present with autoimmune hemolytic anemia or autoimmune thrombocytopenia. Physical examination may reveal cervical, axillary, and or inguinal lymphadenopathy, splenomegaly, and hepatomegaly are not uncommon. Laboratory features, laboratory finding invariable, show lymphocytosis. The ALC can range of 5-10-9. Chronic lymphoblastic leukemia cells resemble mature lymphocytes. They have dense chromatin as well as scant cytoplasm and lack nucleoli. Smear preparation from peripheral blood may damage these fragile lymphocytes and produce smudge cells. The extent of bone marrow infiltration varies in terms of percentage of marrow involved as well as in the pattern of involvement, which may be nodular. Diagnosis in 2008, the International Workshop of Chronic Lymphocytic Leukemia, along with National Cancer Institute, update recommendation on the diagnosis and treatment of chronic lymphocytic leukemia. The diagnosis of chronic lymphocytic leukemia requires at least 5 times 10⁹ B lymphocytes. And in peripheral blood flow cytometry is used to confirm the clonality of circulating B lymphocytes. And continue another. Treatment, different chemotherapeutic agents using and monoclonal antibodies and some novel agents in development. Stem cell transplantation, autologous transplantation has been shown to produce high curative rates in patients with chronic lymphoblastic leukemia, but is associated with high relapse rates. Allogenic transplantation has demonstrated more durable remissions, albeit at the expense expense of higher attendant toxicity. Of course, more practical than other not autologous, other allografts, allo transplantation and others, easy but more problematic. Supportive care, patient with chronic lymphogenous leukemia can have a host of complications ranging from hematologic to infectious. Supportive care maneuvers are delineated. Autoimmune complication of chronic lymphogenous leukemia, autoimmune hemolytic anemia, autoimmune thrombocytopenia, and poor red cell aplasia develop in some patients with chronic lymphoblastic leukemia. Hypogammaglobulinemia is a frequent complication of chronic lymphoblastic leukemia because of the high cost of therapy and its limited activity in preventing serious infections monthly. Intravenous gamma globulin replacement therapy is usually limited to hypogammaglobulinemic patients who experience repeated pneumopulmonary bacterial infections. Hairy cell leukemia. Hairy cell leukemia is an uncommon B-cell lymphoproliferative disorder affecting adults and represent 2% of all leukemia. There is marked male preponderance. Most patients have cytopenia. Splenomegaly is also frequent at presentation. And continue. That's all this program. Superficially, not deeply, just like physicians or oncologists. Chronic myeloid leukemia. Chronic myeloid leukemia. Introduction. Chronic myeloid leukemia is a pluripotent hematopoietic stem cell disorder leading to myeloproliferation and its attendant consequence, the BCR-ABL rearrangement, the pathognomic molecular abnormality in chronic myelogenous myeloid leukemia imparts a proliferative and survival advantage to the malignant clone, leading to accumulation of leukemic cells. Patients may present with characteristic clinical findings caused by large numbers of circulating and bone marrow myeloid cells, such as splenomegaly, leukocytosis, or even isolated thrombocytosis. Often patients are asymptomatic at diagnosis and are discovered only incidentally to have the disease. in the setting of the routine complete blood count performed for an unrelated reason. A plethora of exciting discoveries have taken place in the understanding of the biology of the disease and in the advancement of therapy for chronic myeloid leukemia. The elucidation of the disease entity at the molecular level and the dramatic impact of the first truly targeted therapy, imatinib mesillat, has served to single out the chronic myeloid leukemia story as the model for modern molecular medicine and the era of personalized targeted therapy. Epidemiology and etiology. In 2010, in the United States, an estimated 4,870 cases of chronic myeloid leukemia will be diagnosed and 440 patients will die of the disease. There has been little change in the incidence of chronic myeloid leukemia over the preceding decades, but the mortality has been greatly reduced. Chronic myeloid leukemia is exceedingly rare in children with a median age at diagnosis of 67 years and the incidence increasing with age. There is a mild male predominance in incidence of the disease with the ratio of 1.3, 2.2, ratio 1. There are no known hereditary, familial, geographic, or ethnic associations. The exact mechanism that initiates the induced translocation represented by the Philadelphia chromosome, the initiating molecular event in chronic myeloid leukemia, is incompletely understood. BCR-ABL is only present in the hematopoietic cells, but it has been found using very sensitive PCR methods in the hematopoietic cells of 25 to 30% of healthy normal volunteers. This raises interesting questions about the role of the gene product in the development of the disease and the need for a yet unknown second hit. There does not appear to be any chemical or infectious associations with the development of the disease, although an increased risk has been noted with exposure to ionizing radiation. Clinical features and natural history. Chronic myeloid leukemia can generally be divided into three separate phases of disease: a chronic phase, an intermediate or accelerated phase, and an end stage blast phase. It is important to note that the natural course of the disease may not always include all of these phases or necessarily follow this specific order. Approximately 90% 90% of patients are diagnosed in the chronic phase at the time of diagnosis and frequently while asymptomatic when symptoms are present. They typically are due to splenomegaly, abdominal pain, abdominal mass, increased satiety. Less common patients may present with catabolic symptoms of hyperuricemia, anorexia, unintentional weight loss, unexplained fever, or consequences of thrombocytopenia such as petechiae, ecchymosis, or hemorrhage, or symptoms of anemia such as fatigue. Patients in chronic phase are usually not more susceptible to infection than healthy individuals. Leukocytosis is commonly found with white blood cell counts that can be higher than 1,000 times 10^9 liter and could in rare instances lead to the catastrophic consequences of hyperleukostasis, including retinal hemorrhage and signs of hyperviscosity. Retinal hemorrhage and signs of hyperviscosity. Priapism, cerebrovascular accidents, tinnitus, confusion, stupor. But this occurrence is less common in the modern era. Historically, prior to the imatinib era, the median survival for patients in chronic phase was 4 to 5 years, with an estimated 15–20% risk of transformation to the blast phase per year. Accelerated phase chronic myelogenous leukemia is characterized by increasing arrest of maturation, heralding transformation to the blast phase. Criteria derived from multivariate analyses that indicate progression to the accelerated phase include 15% or more blast, 30% or more blast plus promyelocytes, 20% or more basophils, platelets lower than 100 times 10^9 liter, unrelated to therapy or cytogenetic clonal evolution. Other criteria have been proposed, but some of the classifications, such as WHO proposal, have not yet been clinically validated. The criteria used to classify patients in the accelerated phase impacts the expected outcome of patients when less strict criteria are used, such as those proposed by the ABMTR on the WHO. WHO, the expected outcome is significantly better, perhaps as a result of patients with less adverse clinical features being selected. Median survival for patients in accelerated phase is 1 to 2 years, and significant numbers of patients may die during this phase of the disease without transforming to the blast phase. Recent evidence suggests that imatinib is changing the natural history of advanced stage. and continue. Diagnosis and initial clinical workup. Initial evaluation include history and physical examination. Symptoms may include abdominal discomfort or pain, fevers, night sweats, weight loss, early satiety, left shoulder pain, sign. Keher sign, indicative of splenomegaly and possible splenic rupture. Anorexia or joint pain. Particularly attention should be directed to any complaints of bleeding, abnormal fatigue, petechiae or other. Petechiae is type of bleeding. Ecchymosis, petechiae, and different style or other. Skin lesions, easy bruisability or visual changes. The family and social histories are the particular importance as the documentation of existence of siblings and details their health status should be noted as allogenic stem cell transplant might be an option at some point during the treatment of chronic myelogenous leukemia patient. Physical examination should note the presence of organomegaly and other signs of extramedullary hematopoiesis. Skin should be assessed for signs of cutaneous involvement, although this is infrequent. Signs of anemia and pallor, dyspnea, and thrombocytopenia in ecchymosis, petechiae should be noted, otherwise a complete physical examination should be undertaken. These articles continue, but we must cut and continue the different subjects. Different chemotherapeutic agents and protocol processing regimens should have been explained as detailed. Stem cell transplantation. Allogenic stem cell transplantation was for many years the treatment of choice for younger patients because of its potential for cure. However, with the introduction of imatinib and second generation tyrosine kinase inhibitor, there has been a paradigm shift in thinking with an also stem cell transplantation no longer recommended as first-line therapy, and so on. And last topic, future directions. Imatinib has changed the understanding, management, and natural history of chronic myeloid leukemia and constitutes today the standard of care However, it is possible to consider that we will need the combination therapy to prevent the development of resistance and increase the probability of achieving complete molecular remission and eventually cure. For the purpose, the many molecular events that occur in the chronic myeloid leukemia are being targeted for development of drugs that may affect them. These drugs in turn may be combined with imatinib. In addition, the next generation of more potent tyrosine kinase inhibitors will be increasingly used. Whether their right place will be multi-combinative, for instance, whether their right place will be replacing imatinib in instances when imatinib fails, or in combination with imatinib to improve the responses and prevent development of resistance, will be defined in the near future. That's all this program, and thank you very much. Thank you so much. You are patient. Every day, step by step, our programs improving, developing direction of deep and progress. But once information and scientific comments, our new discoveries and techniques and theories, you should have been found. Our headquarters network address www.youtube.com/Efruzhu Cancer Theory and related links. Thank you very much. Thank you so much. See you later.